All right, good morning. Can you guys hear me okay? Hello? Is this loud enough? All right. Can you guys hear me okay? All right, welcome everybody. My name is Dr. Izora. As you can see, I'm the blog director for endocrinology. So over the next 3 weeks, we'll be working together to explore endocrinology, okay? The goal is for you to be successful, in your exams, but also in your clinical practice. So I do welcome, questions, emails, as you study. If you have anything that comes up that will help you, anything that we can discuss to help you, understand the concepts better, please reach out, either myself to any of the faculty. The way we're going to have this session, I sent you slides ahead of time. I would strongly encourage you to, try to take notes on the slides because besides what's on the slides, we're going to talk a lot about other things, explaining the slides and things. So take notes so that when you're doing your review later on for the exam, it will be easy to reference. I think those are the main things. For each faculty member, you're going to get the slides ahead of the session. I strongly encourage you to also read the text. There's some on your syllabus. There's the assigned reading. Try to read it as much. I know that you have a lot going on, but try to read ahead of the class. That way you can, it's a lot easier to follow the content when we're talking about it if you did read ahead of time. Okay? And the exam, ultimately, at the end of the block. How was the GI exam, by the way? Was good? Yeah. So the idea is to, my approach to teaching is to make sure that you get the content, okay? Understand it because, of course, number one goal is to pass your exams, but also I want you to also get the content because as a physician, you're going to encounter all these things. I didn't think so when I was at your stage, but now I know because I use a lot of these concepts in everyday practice. So understand that the goal is to, for you to understand the content in a way that you won't forget it over the long term, okay? So with that said, we'll go ahead and get started. These are our learning objectives. So define the basic concepts of hormone synthesis, secretion, action, and regulation common to all hormones. Describe the difference between peptide, amine, and steroid-derived hormones. Correlate properties of peptide, amine, and steroid-derived hormones with their actions. I like to start, this is fundamental, but I'm trying to make sure that we're all on the same page. Some of you have done some endocrinology, some have not in the past, but, the hypothalamus is considered the control center for the endocrine system, even though the pituitary is what we know most of the time, but the pituitary is where the hormones are often made or stored. So, but the hypothalamus has nuclei, nerves that go to regulate the pituitary. And then pituitary releases tropic hormones that then go to the target organs. Okay? The target organs produce the effector hormones. Okay? And those hormones are what has, carries out the action of the hormone at the different sites. And then there's a feedback that, sends back to regulate the production of those hormones through the action of the hormone on the hypothalamus and the pituitary. Okay, so this is kind of the general organization of the endocrine system, and you're going to see this all the time. We use these relationships all the time to make clinical decisions, understanding how hormones work. These are the key endocrine organs, the hypothalamus, pituitary, thyroid, adrenal, ovaries, pancreas, and the testes. And we talked about, you know, these are the parathyroid gland and the pancreas. I circled them for a reason. Did anybody think, did you consider why these were circled? What's common between parathyroid gland and pancreas in terms of how they function and how they're regulated? Is there a pituitary hormone that regulates the parathyroids? How about the thyroid? What regulates the thyroid? Thyroid stimulating hormone, right? But there's no parathyroid stimulating hormone, is there? Or pancreas stimulating. So what regulates the parathyroids and the let's start with the parathyroids. What regulates parathyroid hormone secretion? Calcium. Yes, because that's what the parathyroid glands do. They regulate calcium. So they respond to feedback from calcium. Okay? So if the calcium is high, parathyroid hormone levels go down. If the calcium is low, PTH levels go up. Okay? The same thing for pancreas. Insulin. What regulates insulin secretion? Why do we make insulin? And by the way, please feel free to speak up, okay? The goal of this is for you to learn, and my experience is that the more you speak, the more you actually, kind of understand what we're talking about, and it's easier for you to remember these things that we're talking about. But insulin is regulated by, I heard somebody says glucose, okay, so glucose. And yeah, and the point of this is to recognize that not every endocrine organ is under the direct regulation by the hypothalamus and the pituitary. So these are the exceptions. So they are regulated by the products that they make. Okay, so that is, kind of a deviation from the classic endocrine, system where you have a pituitary hypothalamic axis that is driving the hormone action regulation. So, and that's important to recognize because, again, when you're thinking about disease processes, okay, if, for example, someone has a, pituitary surgery, okay, I don't expect the parathyroid to be abnormal, right? Even if you destroy the pituitary, during the surgery, I don't expect to have any parathyroid issues. I mean, there could be other connections that can affect the calcium, but bottom line is that the primary function of the parathyroid will not be impacted by a pituitary dysfunction, okay? All right. So the next, hormone signaling, this is another concept that is important to understand. So you can have what we call, where a cell makes the hormone and the hormone acts locally, and that's called autocrine signaling, where the same cell produces the hormone that actually affects that particular cell. You have this in the ovaries, where the estrogen will enhance FSH effect on the granulosa cells. The granulosa cells make estrogen, so they affect how they respond to FSH. And then also in the islets, you have that as well in insulin regulation. But you can also have adjacent cells that produce a hormone that acts on neighboring cells. So that's called paracrine. Okay, so in this case, you have like islet cell also. The pancreas has alpha, beta, delta, right? So there are lots of cells, and those different cells make different hormones. And because they're so close together, they have a lot of interaction. And somatostatin suppresses insulin and glucagon. So that's one of the effects of somatostatin made by the delta cells of the islets. And then finally, the most common is the classic endocrine signaling, where you have a distant cell that produces a hormone that goes to another cell to kind of act on the cell to produce a hormone like TSH from the pituitary, going to the thyroid gland to make thyroid hormone and ACTH. So this is, again, just some basic concepts to recognize. And there are implications for this. For example, if a hormone has to go from one cell through the bloodstream to another, the nature of that hormone becomes important. Can it travel through the bloodstream? So how do we make it to be able to travel through the bloodstream? Okay, that's the implication of this relationship. And this is more like, to look at all the hormones that are made by the different lines in the pituitary. The pituitary has the anterior pituitary. Dr. Marchant will be going over the anatomy with you later this morning, but, the anterior and the posterior pituitary are different. Most of the hormones are made by the anterior pituitary. Okay? The posterior is more like a storage vesicle or a storage structure for hormones that are made at nerve endings. Whereas the anterior is actually cells that produce these hormones. So it's a little bit different, but these are the different hormones and their actions. And over the course of these 3 weeks, we're going to go over all of these hormones. I think with the exception of the gonads, I think you do that more in the reproductive reproduction section of the block. Okay? So what are the types of hormones that we have? So peptide hormones. These are the probably the more common hormones that there are. They are proteins synthesized from encoded message. That's the DNA. So just like every protein synthesis that happens in the body, the messenger RNA translates the message, and then you produce hormones or amino acid chains, essentially, that are processed like every protein. So there are prohormones that are cleaved and undergo processing in the endoplasmic reticulum, and then they become active hormones after the cleavage or the post-translational processing to lead to and are stored in secretory granules that are released by exocytosis when there is a signal for that hormone to be released. So, for example, if, say, TSH, goes to the, not TSH is not a good example. Insulin. Okay, insulin is made in the beta cells and is produced and stored. And when there's a signal, so when the glucose levels go up, there are some changes that happen. We'll go into the details. That leads to release of the insulin, and then you have the insulin action. Okay? So what are some other peptide hormones you can think about? So we've talked about insulin. I gave some examples in the text, in the slides, but what are the other peptide hormones that you can think about? Well, testosterone, is that a peptide hormone? Okay, I'll take oxytocin. It's a peptide, nanopeptide. This is the easy one, right? So what are the steroid hormones? Let's start from there. That might be easier. We're going to get to that. If you remove all the steroids, remove all the amino acid-derived hormones, you're talking about peptides. Everything else is a peptide. So most of the pituitary hormones, all those releasing hormones, FSH, LH, TSH, they're all, pituitary, they're all peptide hormones. Insulin, PTH, these are all peptide hormones. And so those are some examples. The amino acid-derived hormones includes just catecholamines and thyroid hormone. Okay, they're synthesized from the amino acid tyrosine. As you can see, thyroid hormone is, diiodotyrosine and monoiodo. So it's 3 iodine. You can see the iodine one here, and this one has 2 iodine molecules. And when you have 2 of these bind together, it gives you T3. Okay, or if you have 2 of these combined to one another, you have T4. So essentially, it's just binding of iodine to tyrosine molecule. What the catecholamines, similar structure. The epinephrine and norepinephrine and dopamine. Okay, and then the steroid hormones. This is the second big group, derived from enzymatic modification of cholesterol. So again, we often think of cholesterol as bad, not good for you, but it does have a function. These hormones are made from cholesterol modification. often in the key organs that make steroid hormones are the adrenal cortex, the gonads, the corpus luteum, and the placenta during pregnancy. And all steroid hormones have the steroid nucleus, so that has A, B, C, and D rings. And then there's the side chains are modified to give you the different forms of the hormones. Examples. Testosterone. Okay, now we can say that. That's correct. Estrogen. Good. Which one? Progesterone. Okay. Cortisol. Estrogen. Okay. Aldosterone. Right? And vitamin D. Even though it's a vitamin, but it has a steroid. It's made from cholesterol. It was classified as a vitamin when it was discovered, but not to confuse you. Just you can consider. Just know that it's classically it's a hormone, but it's classified as a vitamin. All right. So moving on. So this is the steroid synthetic pathway. You're going to see this a lot, especially when you do the adrenal section, and also maybe in reproduction. And this, I just wanted to highlight that this is a clinical kind of implication of hormone defect in hormone synthesis. You've heard of 21-hydroxylase deficiency. Okay, the cholesterol produces aldosterone through this line, can produce cortisol, and then adrenal gonads. Okay, this happens in male and female. So remember that even women do make testosterone, but in very small amounts in the adrenal glands, whereas men make a lot more testosterone, mostly in the testes. But in women, if you have a female child, for example, and the person has deficiency in this hormone, 21-hydroxylase deficiency, okay? What's going to happen is the cholesterol, they're going to be deficient in cortisol and aldosterone, okay? And because you have low cortisol, what does the pituitary do? What stimulates cortisol production? What's the hormone that comes from the pituitary to stimulate cortisol? ACTH. So if the cortisol is low, what happens? It goes up. So there's more ACTH, so it's stimulating the process, but the problem is blocked. So what happens? You have excess production of adrenal androgens. So that's why you have excess androgen in a female patient that has 21-hydroxylase deficiency. So it's called congenital adrenal hyperplasia, and often the patients will present with signs of, virilization, excess androgen, from childhood. And I believe this is one of the childhood screening that is done when the child is born, because it's definitely important to recognize this early enough to address it before the child develops. And we'll talk more about this later on in the subsequent sections. So we'll talk about hormone transport. And by the way, if at any point you have any questions, please feel free to raise up your hand or just shout out the question, okay? Hormone transport. So a hormone can transport, it can be free, okay, often because the plasma is water-soluble. So if you have a water-soluble hormone, it can travel free in plasma. So peptide hormones, proteins are water-soluble, so they travel free. On the other hand, cholesterol, steroid hormones are non-polar and they're hydrophobic. So that means they require something to make them able to move freely in plasma. Because without a hydrophilic medium, they can't move from the cells where they are produced. For example, in the adrenal gland, you make testosterone, for example, or in the testes or in the ovaries, you make either estrogen or testosterone. Without having the hormone bound to something, so a binding protein that will help to make it to be able to move through plasma, it can't diffuse from the organ that is produced to the target organ because it has to move through plasma. So if it's fat soluble, then it will just stick around. It can't move. So you need the transport to take it there. So think of it like, and there are implications of having the binding protein, because if you have deficiency in the binding protein, you might have deficiency in the binding of the hormone to the protein, and that can affect your measurements, and we'll talk about that in the subsequent slides. But it's important to recognize the different, the key distinction between the peptides, which can travel free in plasma, and the steroids, which need a protein, hormone binding protein to travel. Cortisol, CBG, corticosteroid binding globulin, binds the corticosteroids. SHBG, sex hormone, binds the testosterone and estrogen. Thyroid binding globulin. Thyroid is made from an amino acid. However, it's a hydrophobic, okay, and it's non-polar. So it behaves like a steroid hormone, even though it's derived from an amino acid. But it behaves very similar to the steroid hormones. And then other less common, the IGF binding protein. But also albumin. Albumin is, is a non-specific binder. So oftentimes in clinical practice, we can't measure like SHBG. I mean, we do, but, or corticosteroid, CBG. So what we do, we measure albumin, because we know that the production of albumin will correlate with the production of all the other proteins. So if the liver is working fine, it makes albumin, then it should be able to make CBG, SHBG. But if there is a problem, if the albumin level is low, then we'll assume that the other, the binding proteins are low as well. So in clinical practice, you're going to see a lot of labs. Albumin is almost on most panels. So it's easy to use that as a surrogate and to assess if there is a protein binding issue, hormone binding protein issue. Okay? So question, is a bound hormone able to act on its receptor? Yes or no? You guys are very quiet today. I want us to be, volunteer answers, interact. Say they can't. I mean, it's 50-50. You can toss a coin. Okay, but that's the correct answer, because when it binds to the protein, okay, it's not free, right? The protein folds, keeps it, so that it can travel to plasma. So the binding site to the receptor is not available until it's in a free form. Okay, so think of it that way. So when a protein is bound, when a hormone is bound to its binding protein or to albumin, okay, it is not available to the receptors. So that's important too. So because again, differences, in the binding proteins level, disease states can affect the availability of a hormone because of the fact that it's dependent on the binding protein. All right. So clinical correlation. So we have a 48-year-old man with compensated liver disease, okay, liver cirrhosis, okay? He was referred for endocrinology evaluation because of low testosterone, okay? He reports no specific symptoms, has normal libido, and shaves every day. His lab shows a low total testosterone of 290. That's the reference range. Then he asks if he needs to start testosterone replacement. So what would you recommend? Let's think about this. How will he approach this? So what do you guys think? So I hear a lot of talking. So let's hear, what are you guys talking about? Okay. Fix albumin, fix testosterone. Okay. That there's some problem with the transport? Okay. Protein binding. Okay. Good. well on the right track. I want us to get home. So, any other thoughts? So, you're both correct. So it has to do with the protein, obviously, as you can see, because the liver makes the SHBG, right? So if you have low albumin and low SHBG, what happens? The total testosterone will be low. Okay? So, and now, we talked about how a bound hormone is not available for action. So if a hormone is bound, it's not available to act. So it's not relevant, really, the total testosterone level. In clinical practice, it doesn't matter. Let me put it that way. What matters is the free testosterone level, okay? And that is why, in this case, we have this patient that has a low total testosterone, a low albumin because of liver disease, but he's asymptomatic, right? Most hormones that are bound to proteins are more than 90% are bound. So most of the protein that you measure is the bound protein. The free one is usually a very small amount, such that the body knows, if there is a low binding protein, the body knows, so the bond between the binding protein and the hormone is not as tight. So it acts as a kind of a buffer or as a regulator of the hormone level. So I'll say that again. The body knows, if there is low protein, okay? So there's a low total testosterone. The bond between the testosterone and the albumin and the SHBG becomes weaker, so that there is more free, because what really matters is the free portion of the hormone. So the body adapts to the low protein states and just releases more free hormone. So many times you might have a low total testosterone, but the body has adapted and released the free. So in this case, what would you recommend is, I would say, we need to check your free testosterone levels. Okay? If the free testosterone level is fine, and we see this a lot, then we'll say, we don't need to do anything. Let's focus on your liver disease and try to get your liver disease, if we can. Okay? So in this case, I don't know if it's too far away. So testosterone in plasma is mostly bound to SHBG, okay? And in patients with liver disease, there is decreased SHBG, resulting in low total testosterone, okay? And although total testosterone may be low, the free testosterone is normal. Hence, patient does not have symptoms, okay? Make sense? All right, so this is, we see this all the time. We get patients referred. This is a classic example of a kind of a referral that I get. Patients are referred because they have low testosterone, but when you check, the free testosterone is normal. Many other things can affect the SHBG level, things like, old age, a high BMI. These are things that can affect SHBG level, and oftentimes that can lead to misinterpretation of the results. All right, so we'll move on. Effect of hormone binding. So binding of a hormone to the hormone binding protein, the protein as a reservoir, okay? Because we already talked about this. The hormone in the bound pool is inactive. So it's there in case the body needs to release more hormone, then it will release more hormone. Okay, think of it as a bank. It banks all the hormone. Okay, and if you need to release, or the Federal Reserve, you pump money into the economy and things. Okay. And then also decreases clearance. Because proteins are large molecules, they're not easily cleared by the kidneys. So because of that, it prolongs the half-life of the hormone. So most hormones that are bound have long half-lives. That's why steroid hormones tend to have long half-lives. Thyroid hormone has a half-life of 8 days. Okay, T4. And then of course, we talked about the plasma solubility, the effect on plasma solubility. So because of the protein, it makes it more soluble. Okay? Any questions? Okay. All right, so moving on to hormone action. how do hormones interpret their message at the target site? I think this is obvious. I put that just for us to consider. Hormones bind to the receptor, and then that leads to the hormone action, okay? Receptor can be on the surface, it can be in the nucleus, okay? So depending on the type of hormone. These are membrane receptors. Hormones that have membrane receptors, what kind of hormones are they? What hormones cannot go through the lipid bilayer of the cell membrane? Peptides. Okay? So peptide hormones act on the surface. They have surface receptors. On the other hand, which hormones can go through the lipid bilayer? Steroid hormones. So that's the distinction. Because it's lipid, in a lipid phase, a lipid hormone can go through, but a hydrophilic hormone cannot. So that's why they have to stick to the surface receptor. But they do have, they transmit their signal through second messengers. So they bind and they lead to changes within the cell that lead to the action of the hormone within the cell. Most hormones and most processes in the body involve some sort of protein synthesis. Okay? So whether it's to make an enzyme or to facilitate something or to make insulin or to make, but when the hormone binds to the receptor, it leads to something. But most of the time, it's either directly binding to the nucleus, steroid hormones, or binding to the surface and causing, using second messengers to kind of have a downstream effect. Insulin and growth factors use the tyrosine kinase receptor, whereas the seven-domain membrane receptor is mostly, most of the pituitary hormones use that PTH as well. Use the seven-domain membrane receptor. I wrote there a clinical correlation. I don't know. I think McCune-Albright syndrome is something that you might see in your text. This is something we see in endocrinology. It has an activating mutation on the membrane, one of the membrane proteins, okay, that is responsible for signaling for the hormone action. So by having an activating mutation in that protein, you have a lower threshold to activate that receptor. So you have early endocrine hyperfunction. So you've heard of the term things like precocious puberty, when the child starts to have puberty much earlier than expected. Okay, that's an example of, one of the things that can manifest in McCune-Albright syndrome, where there is, a decreased threshold for activation of a hormone receptor because of a mutation. There are different things, and we'll talk about different hormone receptors, but these are second messengers. Cyclic AMP is the most common, but there are other. In your textbook, there's a list of different receptors. Review that. And then for steroid hormones, like we talked about, because the steroid can pass through the lipid bilayer of the cell, they go into the cell, they have nuclear receptors that lead to, protein synthesis within the cell directly. So again, that's the big distinction between peptide and steroid hormones. I'll tell you that, in my practice now, sometimes I have people come and talk about, receptors and, GLP-1, how you see that these are concepts that you're going to see all the time. Down your career, many years ahead of time, if these concepts are clear to you, you're going to find it very useful when you're trying to either treat patients or do research or do something that has to do with, hormone action or modulation of hormone action. Okay? I think we already talked about this. Thyroid hormone also acts through the nuclear receptors. So that's, again, think of thyroid hormone as, essentially, it behaves like a steroid hormone in almost every aspect, okay, except that it's made from amino acid tyrosine. Regulation of receptors. So one of the things that is also an important concept to remember, receptor sensitivity. You're talking about how responsive is the receptor to the hormone binding, okay? So how much effect does that binding result in? So, and sensitivity is defined as concentration of a hormone that's required to achieve 50% of maximal response. And there's what you call upregulation, which is increase in number or affinity of receptors of the hormone, for the hormone. And then there's downregulation, where you have decreased, so essentially dampening the hormone response, or you can up the response, okay? So these are two concepts. And these are important in physiologic regulation of hormone action. Because, have you heard of the term insulin resistance? Okay. Insulin resistance is when you is a common part of pathophysiology of type 2 diabetes. And we're going to talk about that next week. Where you have obesity. Obesity leads to production of cytokines that lead to insulin resistance. But in an insulin resistant state, you need to make a lot more insulin to achieve the same action. Okay, so in that case, you have downregulation of the receptor. So the receptor sensitivity goes down. So there's resistance at the receptor level, such that the concentration of a hormone that you need to achieve 50% response goes up. So that is insulin resistance because of downregulation of the receptors, because of excess, glucose and cytokines floating around in the circulation. And it's believed that downregulation is done to kind of protect the cells from overstimulation. Okay? Upregulation is when there's not enough hormone, so the cells become more sensitive. They try to maximize the effect of the little hormone that's available. Okay? So summary of the key differences between peptide and steroid hormones. So peptide hormones are synthesized from amino acids. Steroid hormones are synthesized from cholesterol. Storage vesicles for peptide hormones are released immediately for steroid hormones. They're not stored typically. Water-soluble, hydrophilic versus hydrophobic. Peptide, because they're hydrophilic, are free and unbound in plasma, whereas steroid hormones need to be bound to proteins. Peptides use surface membrane receptors, whereas steroid hormones use nuclear receptors. Peptides have short half-life. Steroids have long half-life. And speed of action, minutes, hours. Examples, there are a lot more examples, but these are some common examples. Any questions? Okay. So next, we're going to talk about hormone secretory patterns, and we'll look at pulsatile, episodic, diurnal, and then stimulated. Stimulated is just the typical, in response to a stimuli, either the tropic hormone or the amino acid or the glucose or calcium, so it doesn't have a pattern. It depends on what is going on if there's a stimulus. But for pulsatile, this is an example of pulsatile hormone secretory pattern. So you can see that there are several pulses. This is for growth hormone. And it's really important, in hormone response and action, to have a pulsatile pattern. When you have several pulses together, you have an episode. And it's really like this is growth hormone. And you can see that during sleep, you have increased pulsation so that's when you have most of the action of growth hormone in increasing growth. Whereas during the daytime, you don't have as much pulses. Okay, so those have clinical implications. So why are some hormones secreted in pulsatile fashion? Why not just make it all the time? Why make it in pulses? Yes, very good. So to avoid desensitizing or downregulating the receptors, right? Because if you certain hormones, if you produce constantly, you're going to have the receptors get tired, okay, and they just kind of start to slow down and reduce the action. But if you put it in pulses, you get profound effect, which is why, again, growth happens, at night, which is why they say young kids, you should sleep, the younger you are, the more you should sleep so that you can have more growth hormone and you can grow. But if you sleep less, then you probably will not grow at all. But anyway, so that's the reason. It's because they're secreted in pulsar fashions to avoid downregulation. How about diurnal hormonal variation? This is, again, diurnal implies, changes with daytime, day and night clock time. And you can see this is for cortisol. Cortisol is made, usually there's a peak around 8 o'clock, okay? And then during the daytime, it's usually up and down, but generally lower, okay, during the daytime. So 8 o'clock is like when you wake up in the morning. And, there's clinical implication. For example, when you're trying to measure cortisol, I've had several referrals sent to me because somebody checked the random cortisol at 4 p.m. in somebody that, works the night shift or so, and, it's going to be low, probably going to be low. So the reference range for cortisol was done using 8 o'clock timing. So that's when you expect to have a peak. So if I have such a patient, I try to tell them, okay, let's repeat the levels at 8 o'clock in the morning. And most times, it comes back in the normal where you expect it to be. So timing is important. So when you get a cortisol level and they say it's low, or it's not where it's supposed to be, try to understand what was the timing. And this also applies to, other hormones like, testosterone, for example. And it's believed that what causes the spike in the morning? Do you remember? So there's what you call, that's essentially what wakes you up in the morning. The spike in your hormones. That's what makes you wake up, and I believe the suprachiasmatic nucleus, where you have the sleep-wake, the circadian rhythm, okay, and that's what essentially wakes you up. So that's the dawn effect, or the circadian rhythm dawn effect. So that's in the morning, your hormones peak. You're getting ready for the day. Your body is getting ready, so you mobilize all the hormones, and that wakes you up, and you get going. So timing is important when we're considering hormone measurements. What are some examples to illustrate effects of altered circadian rhythm or diurnal pattern of hormone secretion that you can think about? Melatonin. Okay, that's what kind of plays a role, but I'm talking about what are examples of things that happen every day that you might say, oh, my sleep-wake cycle is altered. Okay. Coma. Night shift. So that's a classic one. So if you do night shift, right, your clock is turned around. So, and that's why you feel sleepy during the day. If you do night shift just one night and the next day they expect you to work during the day, you're going to feel very tired. That's because you have your sleep-wake cycle. Other examples. Okay, insomnia. You can't sleep, so yeah, that can affect in some respect. What else? What about if you travel to the East Coast? What happens? Yes, your time is off. So that's also another example of where the sleep-wake cycle is altered. And also some patients that are, blind, completely blind, sometimes they don't have, because the sun, has an effect on that suprachiasmatic nucleus and the cycling. So sometimes you lose that as well. So shift workers, travel, jet lag, things like that. That's what causes jet lag. Okay. So hormone release and regulation. Any questions? All doing good? All right. So hormone regulation can be hormonal. I think we've talked about this, where you have the tropic hormones. They stimulate the hormone, TSH stimulates thyroid gland to make thyroid hormone. And then through the feedback loops, that's the regulation of that axis. We also talked about nutrients, iron regulated, calcium for parathyroid gland, and glucose for the islets in the pancreas. And then there's neural, which we haven't really talked about, but the adrenal medulla has neural regulation, so it has the sympathetic, chain and all that goes to the adrenals, and that leads to, so their release is based on neural stimuli, okay? That leads to the release of epinephrine from the adrenal glands, okay? Feedback, again, the primary purpose of feedback is to maintain a steady state. So you want to keep the hormone within a specific range, okay? You don't want it to go too high or too low. If it goes too high, the feedback says, okay, let's reduce the stimulation. If it goes too low, the feedback says, let's increase the stimulation. So just like a thermostat, just think of it that way. But just like a thermostat, for the feedback to work correctly, you need to have a closed-loop system. So that's really important. You have to have a product. You have to have the effect of that product. Then you have to have something that will sense the effect to be able to say, is this effect appropriate or not appropriate? And if it's not, we need to make some changes. Okay? So in any hormone scenario, if you suspect a disease process, always think, is this loop intact? Okay? Because sometimes the numbers may be misleading if you don't consider the fact that maybe there's a break in the loop. Okay? So negative feedback, reduction of an initial stimuli by the product of the stimulation. Okay? Protects against excess hormone production. This is a feedback loop. I think we've seen this. This is the feedback. Again, the effector hormone regulates the releasing hormone and the tropic hormone release from the hypothalamus and the pituitary. On the other hand, positive feedback, original stimuli results in an increased stimulation for hormone release. Okay, so instead of reducing the stimulation, you increase the stimulation. What are some examples? Okay, good. Oxytocin. So, and where does that come into play? Okay. So it's during childbirth, oxytocin causes uterine contraction, okay? Uterine contraction, that leads to more oxytocin, okay? Now, then what causes the action to stop, the hormone action? What is the stop? Otherwise, it will keep going, right? You have indefinite contraction. That's not something we want. So how do you stop the action then, the hormone action? What causes the cessation of the action? What do you think? Okay. So most of the feedback in positive feedback has to do with the ultimate action going away. For example, in the case of childbirth, the head of the baby is what pushes against the cervix, and that causes that feedback, But once the head of the baby passes through the cervix, there's no more push on the cervix, so that feedback, that stimulation is gone. So in this case, it's not about the hormone sending the feedback, it's about the action of the hormone leading to, if that action is absent, then the feedback, the hormone secretion will stop. Make sense? The same thing for lactation. Suckling, the breast by the baby will lead to continued production of, prolactin, and that leads to, milk secretion. And once the baby, as long as the baby will suckle, you keep having, milk production. And once you stop, it will start to go down and it will stop. So that's why, again, it's, most times patients that have, after delivery, women are encouraged, if you want to breastfeed, start right away and try to encourage breastfeeding so that you can maintain the secretion. Because once you stop for a while, it might be more difficult to start back. Okay? Any questions? Okay. So hormone measurement. So we measure hormones by, let's see. It can involve direct measurement of the hormone in the plasma. So you can look at the how like things like TSH, okay, free T4, free T3, even insulin levels. Or you can measure the product of hormone action as a surrogate. We talked about growth hormone being secreted in a pulsatile fashion, right? So imagine if you try to measure growth hormone, it goes up and goes down. So if you try to measure it, you're not going to be able to, if you get it at the trough, when it's at the lowest, it might misinterpret it as being growth hormone deficiency. Whereas if you get it at the peak, you might say, oh, it's too much, right? So the way we measure growth hormone is to look at the product. So growth hormone stimulates insulin-like growth factor, IGF-1 production, okay, in the liver. So in clinical practice, if you're trying to assess for when you have excess growth hormone, what do you call it? Excess growth hormone. What does it cause? Yeah, acromegaly. So if you're trying to diagnose acromegaly, okay, instead of checking growth hormone, we'll check IGF-1 because we know that growth hormone is so fluctuant. So we measure IGF-1 as a surrogate, and that tells us, about the state of the growth hormone in the body. In addition, we can also do stimulation or suppression of hormone levels, to diagnose disease states. Here we're talking about where you try to, if you're not sure, for example, a patient comes with a cortisol of, say, 8. Cortisol is, of 8 is kind of indeterminate, but the patient is asymptomatic. Okay, so you want to know, is this really a low cortisol, or is this because, maybe they didn't sleep well? So some things we can do, we employ, I don't know if you've heard of the term co-syntropin stimulation test. Okay, co-syntropin is synthetic ACTH. So we also call it ACTH stimulation test. So in this case, we give synthetic ACTH because, and then that will directly stimulate the adrenal glands, and then we measure the cortisol level. Okay? So we can do that to understand, is the adrenal gland functioning correctly? So even though the cortisol may be kind of indeterminate, if you do that and you have a good response, it tells you, okay, the adrenals are fine. Okay? So that's one way. So you can do stimulation. On the other hand, and we'll talk about this, I think in the pituitary section, I have a illustration, but it's always good to have a head start. But you can have stimulation of hormone production, or suppression. You can try to suppress hormone production by something like a dexamethasone suppression test. So dexamethasone is a synthetic steroid. So if you give a high dose of a synthetic steroid, what does that do to the ACTH level? Up or down? It goes down, okay? Because the brain will say, there's a lot of steroids, so I don't need to make any ACTH. So if you do that, then you check your cortisol level. So you've suppressed the ACTH, you check the cortisol level. If the cortisol level, is low, then that's a normal response because you expect that if you give exogenous steroid, you expect to have a low cortisol. But if you give exogenous steroid, dexamethasone, and you check the cortisol the next day and it's high, it means that there is, excess cortisol, so you use this in trying to diagnose Cushing's disease, okay, Cushing's, where you have excess cortisol secretion. Again, we'll talk more in detail. We haven't gotten to the pituitary section, but this is good things that if you can, understand this concept, it will be a lot easier in the future. So this is, I don't know, probably you did this in immunology maybe, where you do ELISA and radioimmunoassay. So in trying to assess a hormone, this is just kind of the general concept or general approach to measurement of a hormone. So the red dots represent the hormone from outside, so the patient's blood sample. Then it's, you mix it with antibody, precipitate it with, an antibody binding process, and then you mix a known amount of a hormone that is known, a known quantity of a hormone with the mixture of the bound exogenous hormone, okay? So depending on the concentration of the exogenous hormone, there will be displacement by the known quantity of the hormone that you add to the mixture. Okay, so depending on how much, if there's more exogenous hormone, there'll be less displacement, right? Because it's much more than the known quantity. Whereas if there's very little exogenous hormone, like the patient's blood has low level of the hormone, if you add the known quantity of the hormone, there'll be more displacement. So the bottom line is, depending on the concentration of the hormone in the body, in the sample that is added, that will determine how much is bound. And then at the end, it's precipitated. This will work. There's a process to precipitate, the bound hormones only. And the ratio, depending on how much hormone is bound and how much of that has the exogenous hormone, that will determine the concentration in the serum. They use different techniques to assess this. Some use radioimmunoassay where the added hormone from outside is radio-labeled, or it can be color, ELISA, where you use color techniques to assess the hormone level. Okay? And then reference ranges is another important concept to understand. A lot of the times we see reference ranges and we tend to, sometimes we don't interpret the reference ranges appropriately because many times, we see, it's normal. Once it's in the reference range, it means it's normal, but there could be more to that. Remember that a reference range is derived from populations, okay, and gives the expected range for a given measurement. In this case, we're talking about hormones in a defined demographic group. Okay, so for example, if you make a reference range for, let's say, testosterone, okay? Testosterone, like we talked about, is high in males and low in females. So if you get a reference range for testosterone in females and you use it in a male patient, it's going to seem like it's very high. It's way beyond the reference range, right? So that's a kind of a very obvious example of where it's important to understand the reference range. What is the demographic group that reference range defines? That's really important. We also talked about things like cortisol, measurement of cortisol. Cortisol is often measured at 8 o'clock in the morning. The reference range for cortisol is, 8 o'clock in the morning. So if you get a cortisol that is done in the afternoon, you're not measuring apples to apples. You're comparing apples to oranges. Make sense? So you have to understand that a reference range, you have to understand what is the reference population to make sure that reference range is applicable to your patient. Is my patient in this reference population so I can use this reference range correctly? In most instances, the answer is yes. But in some instances, the answer could be no. So if you have a patient that is sick in the hospital, okay, their sleep-wake cycle is messed up, and then you're trying to check cortisol level. It's almost always going to be abnormal. Okay, just because they don't sleep at night, properly, the phlebotomist will come and be jamming. Different things happen. There's a code blue. There's different things. So it's always difficult to sleep for various other reasons. So this is an important concept to understand. And what they do is, so if you get a reference population, let's say medical students across the country, they measure all the medical students, and they measure all your cortisol, and they put it on at 8 o'clock in the morning. Okay, so that's the reference range. Medical students in the United States, 8 o'clock in the morning, cortisol, male, female. Okay, so now if you're going to measure a reference range for someone that's, a faculty member that's not, within the United States, for example, there's a tendency that you're going to have something different. Again, this is just an example. But the point is to recognize that always try to understand what's the reference population for the reference range that we're using for hormone assessment. I think we're almost done. I don't know if you guys want to take a quick break. We're at the top of the hour. We're almost done, but if you want, we can break for 5 minutes and then finish up when you get back. Okay? All right. 5 minutes, and then we'll finish up.
So this was like testing for like receptor affinity to see if there's an issue with the receptors, or
no? This is to All right, let's, I think we've had 5 minutes, right? All right. So, I'll go back because I had a question about this. So, again, this, I don't know how many of you got this clearly, but this is talking about measurement of hormones. So when you order a lab test, for example, this is what typically happens when you try to check a hormone level. Okay? So the red, you have the hormone, the lab will have a pre-measured amount of a hormone that is added to a sample, okay? And that hormone that is already pre-prepared has some sort of way that it can be detected by the lab, either by radiation or by ELISA, like color changes, okay? So then you add the patient's sample to that mixture. So depending on how much of the hormone that the patient has in that sample, that will displace the hormone that you added that is radio labeled or that has a color labeling or something. Okay, so depending on how much is displaced, when you end up trying to measure your outcome, okay, the amount of ratio of displaced of the amount of radiation, for example, that you pick up will be a reflection of how much of the hormone is in the sample that you added to the mixture. I don't know if is that clear? Because I want to make sure you guys understand it. But again, this is more like your immunology, trying to look at hormone measurement. And the other question was about up-regulation and down-regulation. Up-regulation has to do with, this has to do with the interaction between the hormone and the receptor, and how much of the signal or how much of the message of the hormone actually is transmitted as an effect. Okay, in downregulation, you reduce even though there may be a lot of hormone, okay, you downregulate the receptor and reduce the action of the hormone, okay, to protect the body. On the other hand, if there's little hormone, you upregulate the receptor, okay, so that you can maximize the effect of the little hormone that's available. Okay? So how will the following factors influence the interpretation of hormone level? I think we talked about this, age and gender. Okay? So age, some hormones change as we get older. Okay? So those levels are not, always, for example, something like TSH, for example. In older patients, the TSH tends to go on the high end of the reference range, even a little bit above the reference range. Okay, about 4.5, 5, if I have a patient that's 80 and their TSH is 4.5 or 5, I don't bother about it, even though it's outside of the reference range, slightly above the reference range. So that's an example. Testosterone, as we get older, it goes lower. Okay, so sometimes that's, physiologic. And then gender, we talked about gender, effect of gender on hormone level interpretation. That's very obvious. Okay. Then pattern of hormone release. We've talked about this also. Okay. Remember the whole concept of diurnal variation of a hormone. Which hormones are made, that have a peak at around 8 o'clock in the morning. The implication is that if you have somebody that remember that even though you want to check cortisol at 8 o'clock in the morning, if somebody comes and tells you, well, but I work the night shift every day for the past 10 years, their clock is flipped. So their 8 o'clock is not, my 8 o'clock if I sleep regular hours. So you have to make sure you ask the patient, do you sleep, from 10 p.m. to 8 a.m. or something, to confirm that that is an appropriate level, okay? Because when Las Vegas, a lot of patients that we see, they do, night shifts, so that's a very common scenario. So make sure that you confirm, Because even though, yes, we say that you have to make sure that it's 8 o'clock in the morning to make sure you can interpret it, but if the patient doesn't fit the demographic group, if they're not, people that sleep at night and wake up at 8 o'clock in the morning, then it's not applicable to them. So their pattern is kind of, reversed. Then illness and nutrition, okay, effect of illness. When you're measuring a hormone, liver disease, we already talked about the case that we gave about liver cirrhosis, how that can affect, SHBG, and that can lead to, lower levels. Also, illness by itself can also lead to decreased production of certain hormones. Things like thyroid hormone, for example, is very, very prone to illness. In the ICU, we get a lot of consults for patients that have what we call non-thyroidal illness, and that leads to abnormal levels of thyroid hormone that we call euthyroid 6 syndrome. You don't need to know all of that. Maybe Dr. Champion will talk about it on Friday with you when she talks about thyroid. But, just know that, illness, hormones are often measured in patients that are healthy and not ill in the hospital and not malnourished, okay? So clinical correlation, a 45-year-old woman with history of pituitary surgery for an adenoma presents 6 weeks post-op with symptoms of hypothyroidism. Her TSH is 1.5, which is within the normal reference range. Is this hormone level appropriate? Is it an appropriate level? Or what are your thoughts? So you have somebody that had pituitary surgery, then she has symptoms that suggest she's hypothyroid, but her TSH is normal. What do we think is going on? We can take a step back. Let's assume, say she's hypothyroid, what's the normal response to hypothyroidism? If the thyroid is not making enough thyroid hormone, what do you expect the TSH to be? Increased. Okay, but it's not in this case, right? So is there a reason why the TSH will not go up in this patient? Is there a reason why the TSH will not increase in this patient? Why do we make TSH? Where is TSH made in the body? Anterior pituitary. Okay, and she had pituitary surgery. So maybe there's some damage to the pituitary. So this is a scenario where we're looking at a feedback system that may not have a closed loop, right? Because the pituitary surgery could have affected the production of TSH. So even though there's hypothyroidism, but because the TSH, the pituitary, cannot respond to that hypothyroidism, you check the TSH, it looks like it's normal. But that's a very misleading number, okay? Because even though TSH is normal, patient is symptomatic, and they had a pituitary surgery, okay? So how would you confirm the diagnosis? What test would you order? What did you say? Yes, T4. You have to speak up, okay? Yeah, so when you have, because what is thyroid hormone? TSH is not really thyroid hormone. TSH is pituitary hormone. So if you have symptoms of hypothyroidism, you check the thyroid hormone, okay? Especially if it's not correlating with the TSH. Even though, yes, in clinical practice, 99% of patients, their TSH will correlate with their T3, T4 levels because they don't have pituitary surgery. But if you have a patient that has pituitary surgery, that whole relationship goes out of, becomes almost irrelevant. Okay, and we have this a lot. I have patients that have pituitary surgery. They have hypofunction of the pituitary as a result of a surgery. They go to their primary care doctor. TSH is low. This is, I made this so that it's in the reference range, but oftentimes it's in the low range, and because they have hypothyroidism from the pituitary surgery, they're on levothyroxine, right? So what is normal response when you have a low TSH? What's the appropriate thing to do? What does a low TSH imply? In people that are healthy, if you have a low TSH, what does that mean based on the feedback? What makes the TSH to go down? Yeah, so it means that you have hyperthyroidism, right? So you have a patient that had pituitary surgery. Because they're hypothyroid, central hypothyroidism, not because the thyroid is not working. So you put them on thyroid hormone, but their TSH will never come up, okay, because the pituitary is not working. But if they go to their primary doctor, because we normally look at TSH to make clinical adjustments, they see that the TSH is low. They'll be like, oh my gosh, your endocrinology is giving you so much thyroid hormone. We need to back off. So they keep backing off, and the patient gets hypothyroid because TSH, you can't be looking at the TSH. It's not telling you the story. It's like looking at a broken thermostat, and it says, 78 degrees. And you feel cold, and but it's not working, okay? It doesn't matter what the reading says. You have to look at what is actually happening. Okay, so in this case, there's a break in the loop. And in this case, you can't rely on the TSH for making clinical judgment. You have to look at the thyroid hormone itself. And almost always it's going to be low because thyroid gland relies on TSH to stimulate thyroid function. Okay? So TSH is a pituitary hormone that responds to levels of T3 and T4. In pituitary disease, TSH may remain low, even if T3 and T4 are low, because the pituitary is unable to make TSH. Okay? So that's the simple explanation. And then endocrine disorders, just to wrap up, hormone deficiency. So hormone deficiencies, you can have hormone deficiencies, hormone resistance, or hormone excess. Okay? So hormone deficiencies, examples, autoimmune, destruction of the thyroid or the adrenals or the islet cells. So, type 1 diabetes. Autoimmune destruction of the thyroid is, what do you call it? Do you remember? Have you read anything on thyroid? You're going to hear about Hashimoto. Hashimoto is autoimmune destruction of the thyroid. That's the most common cause of hypothyroidism. And then you have autoimmune adrenalitis, which is autoimmune destruction of the adrenal glands. It's not as common, but you can have it in patients that have autoimmune disease like type 1 diabetes. And then you can have deficiency of precursors. So the precursors that are used to make these hormones, like iodine. So fortunately, it's not common in the United States because most of the food in the U.S. is supplemented with iodine. So it's very hard to find iodine deficiency in the United States. But in countries where there is iodine deficiency, you can have, deficiency of thyroid hormone. And that will manifest as goiters because the thyroid tries to function more because there's deficiency, there's increased TSH that stimulates the thyroid gland. It starts to get hypertrophic. So that's one of the causes of goiter, when you have iodine deficiency, but not in the United States. Okay, because, again, you don't have iodine deficiency in the United States. You can have hormone resistance, pseudo-hypoparathyroidism. Again, this is essentially where the PTH receptor doesn't respond to the PTH binding to the receptor. Okay, so you can have hypocalcemia, even though there is appropriate, even high amounts of parathyroid hormone. Okay, so that's it's not a common thing, but just know that you can have receptor defects that lead to hormone inactivity, and then you can have functional resistance. We talked about insulin resistance. Okay, again to clarify, when you have obesity leads to insulin resistance. Insulin resistance leads to increased insulin secretion to overcome the resistance. It leads to downregulation of the insulin receptor. So you can have hyperinsulinemia. So as a matter of fact, when you have in the pathophysiology of type 2 diabetes, which we'll talk about next week, there is excess amounts of insulin, not insulin deficiency. There's so much insulin in the system that there's downregulation and resistance to the insulin to protect the body. So it's not that you don't have enough insulin, it's just that you have so much insulin because there's so much insulin resistance. Okay? And then you can have hormone excesses. So things like, tumors that make excess hormone. We're going to talk about acromegaly. And you can have autoimmune activation. Again, Graves' disease is we're going to talk about Graves' disease on Friday with Dr. Champion, where you have autoantibodies that bind to the receptors and kind of mimic the action of the hormones. Okay? So that's Graves' disease for you. And then when you're talking about primary, secondary disorders, primary means the primary target endocrine system. So if you have things like primary hypothyroidism, it means that the defect is in the thyroid gland itself. Okay, if you hear things like primary hyperparathyroidism, it means that the parathyroid is the cause of the defect. So primary means is a primary endocrine organ that is causing the problem. Then you can have secondary. Secondary means it's not the primary organ, that the hormonal dysfunction is in response to something else. So you can have defects in the pituitary or the hypothalamus. Okay? So primary, secondary hypothyroidism, for example, or central hypothyroidism is because of things like pituitary dysfunction post-operatively. So that's all I have. Questions? Okay. So Dr. Marchant is here, so thank you for that. The next section we're going to go over anatomy and some anatomy of the endocrine system. And then on Friday, Dr. Champion will be here for the thyroid. And then next week we'll pick up with diabetes. Okay? I'll send you some information in the web campus. And then we're having this conference right now, the ACE conference. It started today. I snuck out so I can give this lecture. And I know that you guys have stuff, but you can share with your classmates or with your colleagues, other classes if they can attend. It's on tomorrow, essentially all day tomorrow. But if you're interested, there's an email, awilliams@ace.com. You can share that for anybody that's interested in attending. It's a student day where you come in and kind of get exposed to endocrinology. And I think they have some sensors and things like that you can put on and test. I think there's space for about 10 openings. So anybody that's interested is welcome to share the information. Okay? That's all I have. Thank you.
Let's have a break and come back by 10:35. That's good. Okay, good morning, everyone. And most of the slides that you will find over here, we have already covered in like different courses of anatomy. I have pulled those slides together for you. We are not going to go over those things, but I wanted you to have like everything ready for your step 1 prep time. We are going to emphasize more on histology. We are going to emphasize some of the clinical things. We will also do a few questions which are really critical, like the key things even from gross anatomy that come repeatedly in step 1. We are going to do those questions again. Let's see how many people can answer that at this point. Okay, so yeah. So let's begin. So for this session, I think so Dr. Azuru covered all the rest of the learning objectives. Only the first one is the one that I am assigned to cover. So when we talk about the endocrine system, there are 2 systems in the body that basically controls every target tissue in the body. One is the nervous system, and the second component is the endocrine system. And this system also basically has a connection with the brain because of the hypothalamus, which is connected to the pituitary gland, and that pituitary gland releases hormones which is distributed throughout the body. Also, we find that there are other things like glucose, calcium, blood volume. All those things also releases certain hormones. So together, the nervous system as well as the endocrine system basically controls or maintains the homeostasis. So when we talk about the pituitary gland, what are the key things I want you to know? Number 1, this area is what we call as the hypothalamus. So here is the hypothalamus, and here you can see from the hypothalamus, a pituitary stalk is coming downwards towards the gland. This gland, which resides in the pituitary fossa of the skull, is connected to the hypothalamus by means of this stalk, hypothalamic or the pituitary stalk. The gland has got 2 parts. The first part is the anterior part and the posterior part. Okay? The posterior part is something which has more direct connection with the hypothalamus. The anterior part has an indirect connection with the hypothalamus. And I will explain what I mean by that. So first of all, probably you know this part because Dr. Azoro went over some of the very introductory things. So from the anterior pituitary, you will have certain hormones which are going to be released by the cells in the anterior pituitary. What are those hormones? We have growth hormone, we have adrenocorticotropic hormone, we have thyroid stimulating hormone, prolactin, luteinizing hormone, follicle stimulating hormone. I've given you just the very basic thing that you need to know, like one-liner to remember and recall the most important functions of some of these hormones. But in this course, you are going to go over much more details in various sections. So this is just to know what hormones are released by the anterior pituitary. Now, why I want you to know this one is so that you can understand the histology of that one, okay, of the pituitary gland, the anterior part. The anterior part is a more glandular part, and that's why it is known as the adenohypophysis, okay? Adeno means gland, so adenohypophysis. And this is another name for anterior pituitary. Over here, you are going to find 2 types of cells. One type is what we call as the chromophils. The other one are called as the chromophobes. And that basically depends how they are, how they basically pick up the stains. Now, what you need to focus on are these terms, acidophils, okay, acidophils and basophils. Cells which are more pink in color, as you can see over here, okay. These cells are acidophil cells. Acidophil cells, okay. And why you want to know that one? Because they will ask you, this is about step 1 level question, okay. They will ask you acidophils basically are going to produce which type of hormones. So in the acidophils, there are 2 types of cells or 2 groups of cells, somatotrophs and mammotrophs. Okay, one produces growth hormone, the other one produces the prolactin. Okay, you cannot identify the somatotroph and mammotrophs by H&E stains. You will need immunohistochemistry or some other stains by which you can identify it, and they will never ask you that one. They will only ask you that, okay, acidophils are pink colored cells and what they release. They release these two hormones. The basophils they have blue granules in them, and they are going to produce, they basically have these three groups of cells: corticotropes, thyrotropes, gonadotropes. And the key thing over here is to know the hormones. Acidophils, they are going to release growth hormone and prolactin. Basophils, they are going to release ACTH, TSH, and gonadotropin, FSH and LH. Good? The other type of cells that you find over here are chromophobes. And the only thing you need to remember over here, these are inactive cells. You are not going to find any visible granules over here. So you can see these cells right over here. And these cells, you can see the nucleus, you can see the cell membrane, but you don't see any, the cytoplasm is neither blue or pink in color. Okay? So they are degranulated, basically cells, or they are inactive cells. So these are the two things you definitely need to know. This is a question that comes again and again in histology. Acidophils, basophils, they want you to know this. In case of posterior pituitary, what you need to know? You need to know that the cell bodies of the neurons, they are present in the hypothalamus, okay? And these axons, they descend downward through the pituitary stalk all the way to the posterior pituitary, where they basically have axon terminals, and these axon terminals will release some hormones. And what are those hormones? Those hormones are ADH and oxytocin. So two types of hormones, they are released. So what is the difference over here? That the posterior pituitary doesn't have a glandular structure. It has neurons. It has unmyelinated neurons whose cell bodies, they are present in the hypothalamus, and these the axons, they come over here and in some kind of axon terminals, and the axon terminals will have secretory granules which will store these hormones. Now the other thing that you need to remember over here is this part. The supraoptic nucleus in the hypothalamus basically is related to the production of ADH. Okay, paraventricular is basically related to oxytocin. So those are the like kind of a major thing, hormones that you need to think about. So that is something that will come again and again over here as well as in the neuroscience course. So that is the key difference that you need to know at this point. Now in case of posterior pituitary, again, I have already mentioned that one, ADH, oxytocin, and what is the function of those hormones? Probably we have already studied in the kidney, the course with the renal course. And oxytocin you are going to study in more details in the reproductive course. But these are the basics, some of the functions of these hormones. For the vascular supply over here, for the posterior pituitary, you need to underline this artery, inferior hypophyseal artery. Inferior hypophyseal artery is the one that you need to highlight. So again, talking about the pituitary gland, this is a good slide to think about, identify the hypothalamus, identify the pituitary stalk over here, and see the difference between the anterior and posterior pituitary. The anterior part is more darker in color as compared to the posterior part. Why this is so? Because the anterior part is more glandular. It will have cells which are constantly secreting. So you will have the cytoplasm will be there, the production part will be there. But in the posterior part, you don't see any cells. These are only axons. So because you have only axons and some supporting tissues which is present over there, that's why you find this is more lighter in stain. For the anterior pituitary, how the anterior pituitary is controlled. We talked about the posterior pituitary, that we have nuclei present in the hypothalamus. The axons, they pass through the pituitary stalk, and they release the hormones in the posterior pituitary. For the anterior pituitary, what we have we have some releasing hormones. And these releasing hormones, they are released by the hypothalamus. So we have gonadotropic releasing hormone, corticotropic releasing hormone, thyrotropic releasing hormone, thyrotropic releasing hormone, gonadotropic releasing hormone. So these releasing hormones, they are released by the hypothalamus. And try to understand this concept very, very clearly. So let's say the hormones are produced over here, and they are released into the tissues, in the pituitary stalk. Now, in the pituitary stalk, we have an artery which is coming in this direction, and this is a superior hypophyseal artery. And this artery divides into a capillary network. Okay? Why we have a capillary network? So that these capillary network can pick up the releasing hormones. Okay? From the capillary network, you are going to find a vein, a vessel, which is going to be formed. And then, again, there is a network of capillaries in the anterior pituitary. So those releasing hormones, they are now released into the anterior pituitary and stimulate the acidophils and the basophil cells present in the anterior pituitary to release hormones, which are then again released into the blood. Is this clear? So how many capillary network is present on this diagram? 2. Am I right? The superior one that you see over here, which is more close to the stalk, and the other one is present in the anterior pituitary. So when we have 2 capillary networks and there is a vessel present between them, what is this system called? Question for tickets, whoever raises the hand. What is that system called? Yes? It's a portal system, okay? Shoot me an email, okay? So portal system. How many portal systems are there in the body? Two, wrong answer. You lose your ticket. Okay. 3? He said 3. Okay. Anybody else has any other ideas? 4? No, he's right. 3. Okay. 3. God, send me an email as well. Okay. Where are those? Where are those three systems present in the body? Okay, you all have to retake the GI test on next Friday. Okay. So one is in the GI system. So why it is so difficult? You just took the exam. Yes. The pituitary, very good, very good. So those are the 3 areas where we have a portal system, okay? So we have a hepatic, like in the GI tract, because there is a capillary network present in the walls of the intestine. Portal vein is formed, and the capillary network is formed in the liver, and then we have the hepatic vein, okay? The same thing happens over here. The third system is the renal one. So what we have an afferent arteriole forming the glomerulus, a capillary network, an efferent arteriole coming out of it, and then again we have a peritubular capillary network, and then we have the renal vein is going to be formed. Is this clear? So again you will find there are 2 capillary networks, and there is a vessel in between. Okay. Now this over here is what we call as a hypophyseal portal system, and they will ask, this is one of the board's favorite as well, okay? They ask questions around this area. Okay. Now, because you want to pick up these hormones very quickly and you want to release as well very quickly, so the capillaries over here are what we call as the fenestrated capillaries. And you can see between the endothelial lining, this is the electron micrographic picture, you can see between the cells there are some gaps, okay? And those gaps basically show you that this is a fenestrated epithelium. You want the gaps to be present so that there's a quick transfer of hormones from the blood into the blood from the somatotrophs or from the cells. Now compare this one. When we will look, I will show you that diagram one more time. When we were talking about the anterior pituitary, see how many cells are there. This is full of cells, okay? And when we look at the histological slide of the posterior pituitary, what you find there are not as many cells over here. Why? Because most of this part is made up of unmyelinated axons. So these are axons present over here. The cells that you see in this area, they are less in number, and they are supporting cells, okay? And these supporting cells are called as the glial cells. Glial cells, think about glial cells like connective tissue of the nervous system. So they are just like the other cells that we have in the connective tissue. We have not studied this part. We will talk about the glial cells more in the neuroscience course. But over here, these supporting cells are what we call as the pituocytes. The pituocytes are the supporting cells. You will also find this term which is called as the Ewing body, which is right over here. You see this eosinophilic structure over here. Some of these things, these are actually the axon terminals. Okay, these are axon terminals. So these are swellings because the granules, they are filled over here with hormones. So axonal swellings are what we call as the Ewing body. So this is the line that is the most important one on this slide. Again, this is a electron micrographic structure, the slide showing you the axon terminals right over here in this area. Okay, and you can see the fenestrated capillary lining right over here. So there are gaps over here, and you can see these terminals. They are very close to the capillaries. Why? Because you want to release the hormones quickly. Pituitary development develops from two areas. Number one, you will have one part which is an extension from the heart palate. So this is the heart palate, let's say. What happens? An extension goes upward from the heart palate. Okay, so this heart palate is ectodermal. It is going towards the skull. The other part is coming down from the hypothalamus. So here you can see this becomes the posterior pituitary, this becomes the anterior pituitary, and then there is this part basically degenerates. So now you have anterior pituitary and posterior pituitary. Now this extension from the roof of the heart palate, we have a specific name for it, and I want you to underline that name. That is called as a Rathke's pouch. Rathke's pouch. And most of the time in embryology, they will ask you about the Rathke's pouch, from where it is developing. So hypothalamus is a neuroectoderm. Rathke's pouch is a somatic ectoderm. Okay, so here you are going to find oral ectoderm and neuroectoderm, two different, slightly different ectoderms which are present over here, forming the anterior pituitary and the posterior pituitary. And most of the time they will ask you this part. Now this anterior pituitary, if you basically go into more details, you are going to find histologically there could be three parts that you can identify, or just generally you can identify it as like three components. What are those three components? And you will find these terms in different texts. Number one is called as a pars distalis. Pars distalis is this part. That is the main part, the main anterior pituitary gland. This, you can call this as another name for the anterior pituitary. Okay? Then you will find there is an extension from this part which goes and wraps around the hypophyseal stalk. Now that extension is called as a pars tuberalis. And the third part that you find over here, which is rudimentary in human beings, and that this part between the anterior and the posterior belongs basically to the anterior one. This is called as a pars intermedia. Pars intermedia. Not a very high yield, but just to be familiar with these terms, like like what these terms means. Because some people like to explain this one as pars distalis, pars tuberalis, pars intermedia, and then they talk about lobes of the anterior pituitary. But don't go into that much detail, just have familiar with this idea. Okay? So here is a comparison between the anterior pituitary and the posterior pituitary, and here you can see how the cells are. If you find a lot of cells over here, that should be the anterior pituitary. If you find less cells over here, then you're going to find, you can say this is the posterior pituitary. So I've given you some points so that you can read and compare the two slides. Any questions? Okay. So let's move to the thyroid gland. This is something that we have done earlier, so I'm not going to go over it, but these are the key things that you need to know. The thyroid gland is present deep to the infrahyoid muscle. It is enclosed by the pretracheal fascia, and pretracheal fascia is part of which fascia? Pretracheal fascia is part of the deep cervical fascia, and deep cervical fascia has got how many parts? There are 4 parts of the deep cervical fascia. Okay? And the most important part is which one? This is the second most important one. Which is the most important one that you should not miss? Have you heard about something called carotid sheath? Good? Okay. So that is a part of the deep cervical fascia. Okay, good. Okay. The second thing that comes most frequently in the step 1 exam is the blood supply. So blood supply, they basically ask you a lot about thyroid. So make sure you review this part. Expect questions from this area because this is like a very important thing as far as the gross anatomy of the thyroid is concerned. The lymphatic drainage goes to the deep cervical lymph nodes and the paratracheal lymph nodes, and then parathyroid. These are the same slides that we basically went over in another course. I'll just put it together for you. So just review it. I know the blood supply of the parathyroid gland is the inferior thyroid artery. Okay? Now let's talk about the histology. One of the most unique things about the thyroid is the hormone is not stored inside the cells. It is extracellular. The cells that form this hormone, they are basically what we call as the follicular cells. And here you can see these cells are the follicular cells. So here you can see the follicles. They are lined by the follicular cells or the principal cells. And in the center of these cells, we have something called as a colloid. So colloid is where the hormones are basically stored. Okay? So this is the key thing. This is the key unique thing about the thyroid, that the hormone storage is extracellular. You will find the follicular cells are what we call as a follicular cell or the principal cells, and these are the cells which are going to produce the thyroid hormone, the T3 and T4. Did Dr. Azuro went over these T3 and T4? He gave you some idea about this? Okay, good. So in the central lumen, you have the colloid, and what the term you need to remember is the thyroglobulin. Thyroglobulin, okay? That is another term that is basically used. Now, when you look at these cells, when you look at the shape of the cells, follicular cells, are they squamous? Are they cuboid? Are they columnar? And it depends upon the activity of the gland. So if the gland is inactive, you will find the cells are flat. So it will be squamous or cuboidal. If it is more active, you will find the cells are more columnar in shape. So depending upon the activity of the gland, the shape of the follicular cells will change. The other cells that you will find over here are the cells which are present between the follicles. And this is a good diagram over here. You can see right over here. This cell, which is present between the follicle, alongside the follicle, is what we call as the parafollicular cells or the C cells. And these cells, they are not present inside the inside the lumen of this follicle. It is not present over here. It is present along it. So remember the word parafollicular or the C cells. And what you want to know about this one, what hormone is produced by it, and that hormone is calcitonin. Calcitonin is the hormone that is produced by the parafollicular cells or the C cells. Now these C cells, for embryology, you will find these are derived from the neural crest cells. So these are also neural crest cells, okay? Why something that is called as the ultimobranchial bodies. So if you don't recall this one now, I will show you a slide soon that will basically, we are going to talk about that one. Now this slide is just for your review. When you basically are studying physiology, I found this slide to be very simple and easy to understand, the synthesis of the thyroid hormone. So I thought I will just give it to you as a really an introduction kind of a thing. It has nothing to do with anatomy. If you like it, if you are able to use it and connect it, because I find the synthesis of the thyroid hormone, sometimes it's more challenging. So it's a simplified version of it. Use it when you are going to study the thyroid hormone. Embryology of the thyroid. We did this one earlier in one of the courses, but so how does the gland form? The gland develops from the floor of the mouth or the floor of the tongue. Okay, from the tongue. On the tongue there is a depression between the anterior 2/3 and the posterior 1/3 of the tongue, and that depression is what we call as a foramen cecum. From the foramen cecum, you are going to find a duct is going to descend downward in front of the hyoid bone, passes in front of the thyroid gland, and just below the thyroid cartilage, and just below the thyroid cartilage, it will divide into two lobes like this. So ultimately, it is going to form the thyroid gland. And then in the next step, you are going to find this is going to degenerate. The duct is going to degenerate. Okay? So very simple formation. The only thing you need to remember, it's a midline endodermal structure. It develops from the tongue, from exactly this point, foramen cecum. If you know this part, you should be okay. Okay. The parathyroid glands, and this is a slide I want you to highlight. This is a slide, they have a question from this slide almost in every exam. Even this time, the last time, they had a lot of questions. Everybody got a question. Some people got like 2 questions from this slide. Okay? So remember this slide because they are fond of asking it. Most of the time, they will ask you what develops from the pharyngeal pouch 3. We talked about the pharyngeal pouches when we studied the neck part. So again, these are the pouches. These are the arches that you have, and between the arches on the inside you have the pouches. So this is the pouch number 3 where you will have the parathyroid, the inferior parathyroid developing from there, and the thymus. And typically these are the things that they typically ask you. So underline this one, know this one. Okay? You should know this one as good, like you should not even think about it. And somebody says pharyngeal pouch 3, what develops? You should know the answer. Okay? Pharyngeal pouch 4, again, you are going to find over here we have the superior parathyroid. The superior parathyroid develops from the pharyngeal pouch 4. And one more thing which is develops from there is called as the ultimobranchial body. These are the neural crest cells. And these neural crest cells, they are going to form the parafollicular cells or the thyroid C cells. Okay? So these 4 lines are typically you are going to find these are your board questions. Okay? Very frequently asked questions. So know this part. The key thing to remember that is a part of confusion is the parathyroid, inferior parathyroid develops from the pharyngeal pouch 3. It descends first. So it basically goes downward, and then you have this one coming and becoming the superior parathyroid. So know this part that the inferior glands originate higher but migrate lower. Okay? If you remember this key concept, you should be okay. So in case of parathyroid histology, you need to remember, basically you need to remember like one cell, which is called the chief cell or the principal cells. Okay, and these cells, they have prominent nuclei. So here you can see on the slide, the nuclei, they are very prominent. Okay, and the cytoplasm is like more paler because the nuclei are very darker. So prominent central nuclei. What they produce parathyroid hormone. The parathyroid hormone helps to increase the calcium level. Another thing probably you are going to study more with physiology or in some other session, that parathyroid hormone actually does not act directly on the osteoclast. Are you familiar with these two types of cells, osteoblast, osteoclast? Osteoblasts are the cells which form the bone. Osteoclasts are the cells which eat up the bones to release the calcium. Got it? But what happens over here, parathyroid does not have a receptor on the osteoclast. So what it does, it stimulates the osteoblast. Osteoblast then have something it increases called the rank L or rank ligand. And then it basically goes through a process by which the ligand part is dropped off and the rank basically stimulates the osteoclast cells to increase the activity. So this is like how the osteoblast and osteocyte, they work together, okay? But this is more like a physiology kind of a thing. For my part, you need to remember we have the chief cells. What the chief cells are doing, they are going to basically secrete the parathyroid hormone. Okay. The second part, the second type of cells that you find over here, they are the oxyphil cells. And the key thing, we do not know what is the function of these cells, but what we know is as the age increases, the number of these cells also increases. The last part is about the adipose tissue, which is present around the parathyroid. That also increases with age. So the key thing that you need to focus upon are the chief cells. Okay, let's do this question. Even without reading the choices, you should know the answer at this point. Good? Everybody okay with this one? What is the answer? No? Okay. You know the answer? No? You're between the inferior and superior? Okay. Which LC is leading right now in the leading board? Mount Charleston? Okay. Mount Charleston, have an answer, otherwise you will have to basically give me 15 points. Okay. Okay. Anybody who has an answer? D, inferior laryngeal? Okay. And what is the other term that you can find over here would be? Recurrent laryngeal. So inferior laryngeal or recurrent laryngeal. Okay. And superior laryngeal nerve supplies what? Cricothyroid. Okay. Cricothyroid is an external muscle. Okay. So that will be the external branch or the internal branch of superior laryngeal nerve. External branch, because cricothyroid is an external muscle. Okay, that is the only muscle that you can see from the front. Okay, so what about the internal branch? What it does? Sensory. To which part? Above the vocal folds. Okay, so those are like three things that you need to know about the larynx. And that is the superior laryngeal nerve, know it in detail, inferior laryngeal nerve, because most of the questions are around those areas. Very good. Okay. Let's do this question. This is an easy question, am I right? No? You guys have an answer? You guys have an answer? You have an answer? Good? Okay. What about this group? You have an answer? D is a remnant of the thyroglossal duct. Why it cannot be ectopic parathyroid? And your thought process is because there is an attachment between the tongue, okay, or the cyst is enclosed in the pretracheal fascia. Anytime you are going to basically swallowing or something will happen, the cyst is going to move. Am I right? Those are the two explanations. Either that small cyst, which is basically the remnant of the duct, is still connected with the tongue, or it is still enclosed in the pretracheal fascia, so it is going to move. So parathyroid glands, they are also enclosed in the pretracheal fascia. But they are so small and they are behind, they are posterior to the thyroid, so you won't be able to basically feel them. And they are really very small glands, okay? The other part is the cervical sinus, which typically they ask you in these type of questions, be careful, because the answer could be between, when they talk about the cyst, it could be the cervical cyst, cervical sinus, or it could be the thyroglossal duct cyst, okay? So those are the two. What is the difference between the two? And most of the time in these areas, they are going to either ask you the thyroglossal duct cyst, or they are going to ask you the cervical sinus. And there is one line that you need to remember to solve these questions. But before I tell you that one line, you need to think about what is cervical sinus. Yes, Mohammed.
Is it that the thyroglossal duct cyst will move when we swallow, and then the cervical sinus will not move?
And that is right. But what else? What is it? What about the look? Yes, Munis. That's right. That is also like one of the key things that you need to think about. In the midline, you have the thyroglossal duct cyst. It's always in the midline. Along the SCM, along the sternocleidomastoid, you are going to find the cervical sinus. So if you find there is a mass present along the SCM, think about cervical sinus. If it is midline, think about the thyroglossal duct. So this is a good diagram, and this is the sinus actually. Because what happens, the first pharyngeal arch basically overlaps the other arches, and it closes these clefts present on the outside of the neck. And sometimes a small part remains trapped inside. That is what we call as a cervical sinus. Okay? And this is typically present in this line, along the SCM. If it is in the midline, think about the thyroglossal duct cyst. Last gland that we are going to talk about is the adrenal gland. So for the adrenal gland, key things over here, we have gone through this in the renal, so these are the same slides. Key thing to remember from embryology point of view is cortex is derived from mesoderm, medulla is derived from the neural crest cells. Blood supply is always important for suprarenal gland, and if you look closely to this diagram, you will find the superior suprarenal artery has got multiple branches which goes to the gland. The middle suprarenal and the inferior suprarenal, typically they are only like one. And then you have the venous drainage, and the venous drainage on the right side and the left side, they are different. Hopefully by this time everybody knows this concept. On the right side it goes into the inferior vena cava, on the left side it goes into the left renal vein. What are the other two structures which have the similar venous drainage? What are the other two structures which have the same pattern of venous drainage? Gonads, yeah. Ovaries and testes, yeah. Gonads. Okay, very good. Then about the fascia, we have already gone through it, so this is just review this part. We are going to talk more about histology, okay? So suprarenal glands, they are enclosed by a capsule, okay? And there are two parts of the gland. One is the outer part, which is the cortex, and then the inner part, which is the medulla. Now, when we talk about the cortex, there are three zones in the cortex. And so just below the capsule, if this is the capsule over here, we have the first zone, which is the glomerulosa, zona glomerulosa. The second one is called zona fasciculata, and the third one is called as the zona reticularis. If you forget it, remember the GFR from the kidneys, and the GFR will tell you from outside to inside, glomerulosa, fasciculata, reticularis. Is this clear? What hormones are produced by each zone? Outside we have the mineralocorticoids. What's the name of that hormone? Anybody? Aldosterone. Aldosterone, very good. And then we have the glucocorticoids from the zona fasciculata and androgens from the zona reticularis. So three zones. Which is the most thickest one? Is this one, the reticularis. Okay? Of the three zones. Medulla is going to produce epinephrine and norepinephrine catecholamines. And again, for embryology, this is the same thing I told you before. Cortex derived from mesoderm, medulla is derived from the neural crest cells. So it is ectodermal. Now, for each of these parts, how we are going to distinguish between these parts? So what you need to think about, the outer layer is what we call as a zona glomerulosa. So first thing, you can see the capsule over here, and from the capsule you find some connective tissue going inwards. These are what we call as a trabeculae. And this trabecula, they are going to surround some of the cells in this area. If you look closely, you might be able to outline these things, like right over here. There is this one, then there is this one over here. So the cells are basically enclosed by these connective tissues which are around the cells. If you pay attention to the cells are arranged in clusters, okay? In clusters. They are arranged in groups, okay? And that's why the term is glomerulus, okay? Glomerulus means a collection, a cluster-like thing. That's why the renal capillaries are together. We call it renal glomerulus, okay? So over here, this is the cells are in clusters. So that's why the name is glomerulus. If you look at the cells, you will find there's an increase in nuclear to cytoplasmic ratios. That means larger nuclei are present over here. And that is the line you need to underline. Okay? The rest of the thing is a function. What it is doing, it produces aldosterone. And aldosterone regulation is when the aldosterone is released. It is released in two circumstances. Number one, if there is a decreased blood volume, decreased blood pressure, you're going to find renin-angiotensin system is going to be formed, which is going to release the aldosterone. And the second one, if there is an increased level of potassium, then you're going to find there will be increase in aldosterone. The hormone acts on the distal convoluted tubules and collecting tubules, and what it does, it reabsorbs the sodium, and in this way it tries to increase the blood volume and the blood pressure. So it increases the water retention. The second zone, zona fasciculata, and the name is telling you, fascicles means cord-like structures. Over here you are going to find the cells are arranged more like in one line, like cords, instead of this area. See this area in the lower right part of the slide. They are in clusters, they are in groups. And these cells in the zona fasciculata, they are arranged more in one line. So these are like cord-like arrangement is present over here. And between the cords, you are going to find there are some sinusoids. Okay, sinusoids, they are present. So capillaries are present over here. Sinusoidal capillaries, they are present between the cells. The third characteristic feature over here is, if you look closely over here, these cells, they look like foamy cells. Why they look foam-like? Because there is a lot of lipids present over here. Okay, lipids. Lipids tells you that these are the hormones. They are found by the lipids. So there is an increased amount of lipids over here. So you are going to find lipid droplets present in this area. And so vacuolated, lipid-rich vacuolated cells, foamy cytoplasm. These are the characteristic features by which you can identify that this is zona fasciculata. What it does, it produces glucocorticoids, number one, and it is influenced by this hormone, which is ACTH. ACTH is basically going to stimulate this adrenal gland. ACTH is from anterior pituitary, which will increase the level of cortisol. The third layer over here is called as a zona reticularis. And what happens over here is you are going to find the cells which are slightly more darker in color as compared to the fasciculata. So here you can see you can compare the colors over here on the lower right part and the upper left part of the slide. And you can see the differences in the color. Number one, you're not going to find that vacuolated cytoplasm present in the zona reticularis. And zona reticularis the cells could be arranged in clusters. They can also be arranged as cord-like. So sometimes they say it's a branching pattern of arrangement of the cells. Sometimes they say, some books will say cord-like, some books will say mixed. So it's basically a mix. You will find sometimes there is a collection, sometimes they are in a line. What they produce? They produce the androgens, DHEA, androgens. Of these three areas, histologically, I want you to focus on zona glomerulosa and reticularis. Make that your strong like part. Okay, review that again and again. Make sure you understand you are able to differentiate those two zones. Adrenal medulla, this is the innermost layer. Okay, again, the key thing over here is the origin. It's a neural crest origin. Okay, these cells are called as the chromophene cells. You must have heard of this term, chromophene cells. Why? Because they can be stained with chromium salts. That's why the term has come, chromophene cells. Whenever they talk about chromophene cells, you need to think about adrenal medulla, the cells which are going to produce the catecholamines. So chromophene cells, they are rich in granules. They stain with chromium salts, and they are arranged in. They are loosely arranged. Okay, they are loosely packed cells over here. Now, what are the key things? I don't expect those things that they're going to ask you. They will ask you neural crest cells. They will ask you what hormones are produced by it, definitely, epinephrine and non-epinephrine. But the most important question over here is this one, how it is controlled. So only preganglionic sympathetic fibers, they basically come to this gland. There is no postganglionic fiber over here. Why we do not have a postganglionic fiber over here? Yes. You release what? Aldosterone? We are in the medulla. Medulla is releasing epinephrine and norepinephrine. What is the postganglionic sympathetic fibers they release? Norepinephrine, am I right? The preganglionic fibers they release acetylcholine. The postganglionic sympathetic fibers they release norepinephrine. So when the acetylcholine fiber is coming over here, preganglionic fiber is coming over here, releasing acetylcholine, stimulating the cells to release what? Norepinephrine. So that's why this gland is also called as a modified sympathetic ganglion. Modified sympathetic ganglion. Is this clear? So you do not need actually a postganglionic sympathetic fiber because the cells are releasing norepinephrine. Everybody clear about this? So this is probably the most important concept for adrenal medulla that you need to know. The second important concept over here is about the blood flow. And understand this part over here in the class, because there are like different people write it in different ways. Sometimes it's like, but follow this pattern. This is the most accurate one, I would say, most easy to understand. So try to understand this. This is the last concept for this class. That is the high yield kind of a concept that you need to focus on. So what happens? We have a suprarenal arteries. The suprarenal arteries, they form a plexus under the capsule. So here you can see the plexus which is being formed under the capsule. Now, these plexus will lead into two types of vessels. Some of the vessels, they are going to basically pass over here through the cortex and then reach the medulla. Is this clear? So they are going to basically pass through the cortex and reach the medulla. And as they pass through the cortex and reaches the medulla, they are picking up the cortisol along with it. So cortisol is poured into these vessels, and when this hormone reaches the medulla, it is going to basically stimulate to form more epinephrine. Because cortisol is also a stress hormone. Am I right? We release cortisol when we are in, the body is under stress. Okay, epinephrine is also a stress hormone. So again, when there is more cortisol coming over here, the body thinks that it is under stress, so it will also release more epinephrine. The second vessel over here is what we call as the medullary arteries, because they are just passing directly from that plexus. It is coming directly into the medulla. So there is a dual supply over here. Okay, one which passes through the cortex, picking up the cortisol, and the second one is going directly and supplying the medulla. So dual blood supply is there. This gland is highly vascular, and most of the time, not most of the time, always the endocrine glands, they are highly vascular. That's why you find suprarenal glands, small gland, but see how many vessels are supplying it, 3 of them. Okay, thyroid gland, not as a big mass of gland, but you will find multiple arteries, they are supplying it, because you want to basically perfuse these structures so that they can basically transport or release hormones into the blood. The last thing important for this thing is the vein. Look at the size of the vein. Okay, the central vein, this is pretty large as compared to arteries or the smaller arteries over here. So this is also a characteristic feature. That is a central vein which is large in size. Let's do this question. So some of the components you might not have studied so far, but try your best. I wanted to give you an example how typically this question is asked, so I added a few things. Can anybody figure out what this diagnosis is? Sorry? Acromegaly, very good, acromegaly, because the hands are larger in size, the jaws is larger, the features are coarse, and then you have a tumor in the pituitary which is compressing the optic chiasm, and that optic chiasm is basically, we have problems with the vision. So there is bitemporal Hemianopia. Is this word given? Yes. Bitemporal hemianopia, which means the peripheral vision is lost. Okay? So don't worry about that one. It is telling you there is a pituitary tumor which is compressing the optic chiasm. Okay. So now we need to figure out, that means acromegaly is increase of what hormone? Growth hormone. So what cells we are looking for? What's the answer? A, acidophils. Acidophil cells, they produce what? They produce the growth hormone. Good? Okay. So typically this is a classic like kind of a question that they will give you. First you need to know something, and then they will basically ask you about histology. Let's do this question. You have an answer? Okay. So what is the condition over here? Cushing's, everybody knows that. This is a Cushing. Facial rounding, what is the typical term used in the books for that one? Moon-shaped face, am I right? This is what you are finding over here. Why there is bruising? Fragile capillaries over here. Okay. The other thing is abdominal striae. What is that? Anybody? What is abdominal striae? Say that again. Stretch marks. Why they develop in this condition? Say that. Because of the weight? No, that happens because increased cortisol affects collagen. And collagen is broken down. So when it is broken down, the skin becomes very thin over there. So that's why you have those marks, basically, because of the collagen disorder. Okay? So that's why you have that one. Why we have thin extremities? Because increased cortisol results in muscle breakdown, okay? And muscle is basically going to be broken down, and you will have more gluconeogenesis is going to be formed, and there will be redistribution of fat. That's why, because of that redistribution, you will find central obesity. You will have more fat on the trunk, in the neck, okay? Have you heard this term, buffalo hump or something? Yeah, that is a characteristic feature. That is why it happens. So you will find thin extremities, and then there will be central obesity. So what is the answer over here? Somebody said that one. See, everybody got this one? Okay, zona fasciculata of the cortex. We should not have endocrine as a course, I think so. No? You know all this part. Very good. Okay. So last one is the pancreas, and we are not going to do the pancreas because these are the same set of slides that we just went over in the GI block. There is absolutely no change over here. I just put those 3-4 slides so that you can review it, because they are going to talk a lot about diabetes, glucagon, all these things. So just to refresh it. So this was I don't think so I have anything else other than this, but let me check. That's it. Okay. Thank you, everyone. I will have about 10 questions for you, 8 or 10 questions as a practice questions. Okay, thank you.